So, on behalf of Professor Emeritus Dr. Saeed Sattar and our um, incredible coordinator and producer, Paul Weber, I want to welcome everyone in to today's teleclass. The title of this lecture is Infection Control and Prevention in Long-Term Care Facilities and Healthcare Laundry. Our speaker today, whom I have the honor and the pleasure of introducing, is John Scherberger. You have, for those in the audience who were listening a few seconds ago, he provided a lot of his details on his CV for you already. But what I'd like to bring to your attention is after working for the Navy for many years and in many capacities, he's had incredible experience working in hospitality sectors for hotels and other associated endeavors, eventually moving into more of the healthcare field over time. But basically, he had spent 18 years in these various capacities, focusing on housekeeping and associated tasks and topics like ventilation and, again, keeping things healthy and clean for customers and guests. Eventually, he moved into South Carolina, a state neighbor to Georgia here, where he spent several years doing similar work in the Spartanburg area. But in 2010, he retired from hospital and other endeavors related to infection prevention and environmental services to start up and is principal at the Healthcare Risk Mitigation is a consulting enterprise that he owns. This endeavor, he assists healthcare, laundry, hospitality, and other professionals in enhancing operations through education and incorporation of industry best practices. With that, he has served or provided service and advice to environmental services, infection prevention colleagues in the area, also personal care professionals, and again, another focus with hospital and healthcare and hospitality venues. He is currently a fellow of the Association for the Healthcare Environment, and he is, as you probably heard earlier, just a minute ago, he has had many opportunities for additional training in ancillary processes and activities, all of which enhance his ability in the environmental services area. He currently serves on the advisory committee for the Environmental Services Optimization Playbook program. And in this regard, he is very active in working to find more resources and more information in an effort to help his colleagues, again, in the environmental services area, do their jobs more efficiently and understanding why they are doing what they're doing. He is a regular contributor to numerous trade journals, including Healthcare Hygiene Magazine. Mentioned he has 21 years in hospitality and food service management, as well as 16 years in healthcare. He is a board member, and past president of the Healthcare Laundry Accreditation Council, and having served a total of 6 years in these voluntary positions. With that, I would like to welcome John and let him get started. He has a vast amount of information, all of which will help you understanding the challenges and potential solutions for healthcare laundry as it relates to long-term care facilities. So, John, the floor is yours.
Thank you, Lynn. I greatly appreciate that, your kind words. And I am going to honor the time that people are investing in this telelearning. And just so that you all know, it's entitled Infection Control and Prevention in Long-Term Care Facilities and Healthcare Laundry, handling, storing, transportation of healthcare textiles in long-term care facilities. I recognize that everyone on this call can read, so I am not going to be reading every slide. There's about 60 slides in here, but I plan on hitting the highlights, and at the end of the presentation, you'll be provided with my telephone number, my email address, and any other way that you need to contact me. I will be more than happy to be of service to you. Let's switch to slide number 2. HAIs, hospital-acquired or healthcare-acquired infections, multi-drug resistant organisms, fungi, mold, pollution. And if you notice, there's change ahead. It just keeps on changing, and that's the one thing that we could be sure of, is change is always inevitable. But what I plan to do is help us reduce the risks that we are going to be facing and the challenges that we're going to be facing in the future. Let's look at slide number 4. Proper processes and the tools equal proper results. And infection prevention and control, the IPC, it's the thing I want to really in touch here is it's a practical, multidisciplinary, multimodal, evidence and science-based approach to mitigating and oftentimes removing the opportunities for patients and healthcare workers to be harmed. It's an ongoing effort, and as I said, it's a multimodal, multidiscipline, and no person is an island here. Anyone who thinks that they can do a job by themselves in environmental services and infection prevention and long-term care, I think they need to be looking to a place that they would be happier working in. Next slide. We're looking at the laundry management side. We're going to start on laundry management. It's intended to ensure that a sufficient par level of hygienic healthcare textiles, Hcts, is maintained that are going to meet the needs of the residents. What is a par level? Well, that's the number of turns. It's the amount of linen or textiles that you will use, that you will need. 1 par is what is in use currently. 2 par is what is on the shelf. And the 3rd par is what is dirty right now. So a hospital that is, or a healthcare facility that is looking to keep the just a 3 par, they're going to run short all the time. And so you need to work with a professional in setting up a par level. Next thing is all hygienic healthcare textiles must be maintained and handled in ways that maintain the hygienic nature of the products. Soiled healthcare textiles are handled in ways that minimize the harm to the residents and the staff. And we also need to make sure that the hygienic textiles that we have do not become cross-contaminated. And one thing that I don't have on here is the human body averages a shedding of 700,000 skin cells per day. And when we touch something or when we walk along, we are shedding skin cells. And skin cells are a form of food for bacteria. So even if we go by and we touch a towel or we touch a sheet, we have transferred skin cells and potentially other pathogens and potential pathogens onto the textile. So we need to watch out what we touch, how it's touched, and where it's touched. Lynn Seeholster, who introduced me, has done a retrospective study released back in 2015 that showed hygienically clean laundry carries negligible risk to healthcare workers and residents, provided that the clean textiles, the fabric, and their clothing are not inadvertently contaminated before use. On page 7 of your presentation, we're going to see that for nursing homes, that infections account for up to half of all nursing home residents transferred to hospitals. And they cost between, in the United States, $670 million to $2 billion to treat annually. And the other thing that is sad here is that when a resident is transferred to a hospital, they're moving from what they know as their home, and they're moving into a strange environment. They're losing control of their decisions. They oftentimes become just another number. But the worst part is the mortality rate of those people who move from a nursing home into a hospital can be as high as 40%. Now, we did have an outlier with the COVID-19, and we had thousands upon thousands of deaths from COVID-19, from patients, from residents who went into a nursing home or who went from a nursing home into a hospital and died of COVID-19. But when we look at what causes infections and mortality, the top 3 are urinary tract infections, because a lot of the patients are incontinent, and therefore they have to wear incontinence pads or underwear, respiratory issues, and the soft skin, soft tissue issues. And a lot of that has to do with age. As we get older, we don't want to eat as much, and when we don't eat, we don't take in the nutrition that our body needs to help the skin revive and multiply. Now, on page 8, we're going to see the overall infection rate in long-term care facilities for endemic infections. That's infections that are typical, not pandemic. A range, it's a very large range of 1.8 to 13.5 infections per 1,000 resident days. What does that tell you? What does it tell us? It tells us that our older residents are prone to infections because of age, because of their previous lifestyle, because of a number of issues, including COVID-19. Now, there is a citation here that you can follow, but I'm not going to be reading that. You have access to it. Now, I understand that there are a lot of people here on international that are not part of the United States, that the Centers for Medicare and Medicaid and the Centers for Disease Control and Infection Prevention, not really controlled by those agencies. However, the information is very good, and in my years of talking to people around the world, so many of them always refer to CMS or CDC. And in this case, we're looking at the guidance for surveyors, people who go and inspect long-term care facilities. One of the most important sections is 483.65, which is infection control. And then we have subsections, requirements to establish infection control programs, preventing the spread of infections, and then we get down to linens. And somebody might ask, why is linens on there as a separate entity? Well, we'll get to that. When we look at the challenges that long-term care facilities face on page 10, they are usually low technology centers, which means they don't have all the bells and whistles that you'll find in hospitals. They tend to be, around the world, they tend to be places where older people or people who are long-term infirmed, they go because their loved ones cannot provide the necessary treatment for them. As a trained hospital chaplain, I can tell you that there is a difference between care and treatment. Treatment always deals with the medical side of it, and medical intervention. And care is the human touch. So when I mentioned that older people go into these long-term care facilities, the families can provide the care, but they can't provide the treatment. And care and treatment is not interchangeable. So they have the low technology, which is care. They stay a long time, usually measured in months and years rather than in days. They're typically viewed as communities, not patient rooms. So people are referred to as guests or residents. The residents are more mobile than patients. Patients in hospitals are usually bedbound or required to stay in a bed until they go through their physical therapy. And the payment systems are significantly different. So much so in the United States that it is a barrier to providing the type of premier care that the older of our generation need. Let's go to page 11. Section 4432A of the Balanced Budget Act, back in 1997, modified how payment was made. And the strange thing is that they are paid depending on where they are. Nursing homes, long-term care facilities, they don't get an annual adjustment in what they're reimbursed on. It's very low, so the income is very low for them. Thus, they have a very low need. They have a high need for technology, but they don't have the sufficient funds to invest in the technology. Another challenge on page 12 is staffing. I came from a conference in Buffalo, New York just recently, and one of the biggest complaints is staffing. They cannot be accomplished by taking a nurse from the to the environmental services area, and obviously you can't take an environmental services person and expect him or her to do nursing procedures. It's just not safe. But so often nursing homes have to essentially rob Peter to pay Paul. And so many people understand what a Ponzi scheme is. That means you're taking money from one person and paying somebody else, and then you're taking money from them and paying somebody else, and pretty soon your Ponzi scheme falls. And that's one of the problems that we have in nursing homes today in the United States. We also have that the facility space is inadequate. They are trying to do more with less. They don't have sufficient money to expand very many nursing homes. If they happen to have an on-premises laundry, the machines are the wrong type. They are too old. They don't know how to provide maintenance. We also have the problem with education. A number of people, the majority of people working in environmental services and nursing homes are usually 8th to 10th grade level education. And so the education, the training, the hands-on, on-the-job training has to be limited based on what their abilities are. And I know this sounds like an indictment, and it is, but there's insufficient interest on the part of the owners of a lot of nursing homes to reinvest into the facilities. So a lot of facilities just don't have the best beds. They don't have the best training. They don't have the number of staff people that they really need to provide the residents the proper treatment and the proper care. On page 13, we see in the United States it's called an F tag, F441. It addresses infection control. And it states here that the facility must, there's no can or probably, they must establish and maintain an infection control program designed to provide a safe, sanitary, and comfortable environment to help prevent and develop the development and transmissions of the disease. So there is a requirement, but a lot of long-term facilities do not have a permanent nor a full-time infection preventionist on the staff. They have hired someone who might be required to cover 3 or 4 states, and that's an almost unimaginable responsibility. Now, we also have infection control programs that they have to establish, not just have the employee there, but part of the job is they have to establish a program. And they can't cookie cutter the program because facilities are different. And they can't duplicate an infection prevention program that is found in a hospital because they have different abilities, they have different equipment, different facilities. They all are unique. But one of the things that the infection prevention program requires is the investigation investigates, controls, and prevents infections of the facility. Oftentimes it's impossible to prevent an infection, but that's their job to try to do it. So we try to mitigate the infections. Page 15, preventing the spread of infection, which is one of the biggest problems right now because in a nursing home or long-term care facility, the people are more mobile than people in a hospital. So they like to gather, they like to have communal meals, they like to gather for songs, for watching movies, and they're talking, they're interacting. So there is more chance of a spread of an infection. So the infection preventionists have to set up processes to stop the spread. They have to prohibit employees from with a communicable disease or intact skin lesions from direct contact with the residents or their food. And in today's world, where we have, it's all over the world, where people cannot go to work, or they might have, because of COVID, they stay home, and thus they can't go to work. But sometimes there are people who decide they want to go to work just because they need the money or because they love what they're doing. The problem is that they are prohibited from doing so. It's a catch-22. And if you don't know what a catch-22 is, that is, you want to do something, but you can't do something because something prevents you from doing it. There's always a reason. We look on page 18, the infection control, infection preventionist. There's a lot of duties here. They have to participate in quality assessment and assurance committees. The infection preventionist has a job that is not in great demand, but it is in great need. He or she, and it's typically a woman who does this job. God bless all of these infection preventionists. They're doing something that most people just could not do or would want to do. When we look at page 19, we look at the linens. Personnel, and this is one of the areas that I really get my teeth into. Personnel must handle, store, process, and transport linens so as to prevent the spread of infection. Now, when we look at this, we sometimes think, well, okay, I won't touch it with my hands. But what if they put down the textiles when they're moving it from one area to another, or they get interrupted, and they put it down on the top of a cart or a charging station? They have to remember that charging station might be contaminated, and therefore the textiles have been are thus contaminated. On page 20, I'm going to skip that. It has to do with a lot of regulations that are applicable to the United States. Feel free to go back and look at what we have here. Here's a great quote from Lynn Seeholster from Infection Control Today, back in March 2011. Of all the surfaces in a hospital, a patient, will have the greatest degree of contact with his gown and the bed linens. I would like to adjust this to say that of all the surfaces in a long-term care facility, the patient will have the greatest degree of contact with his or her clothing and with the bed linens. And thus we have two problems. One, their clothing is theirs, and the nursing home, the long-term care facility, has to treat those clothes in one way, and they have to treat their bed linens in another way, which compounds their problem. On page 22, we see there are clear standards and guidelines for handling contaminated HCTs, healthcare textiles. But the sad thing is there's nothing that regarding to the handling, storage, and distribution of the textiles. How do the facilities carry out these directives without standard and accepted practices? Oftentimes, when they're left to their own devices, the facilities will institute appropriate processes or overzealous processes, which is also known as knee-jerk reactions, impotent processes, which means I've got it on paper, but we're not going to do anything with it, or they decide not to have any processes at all. They leave the residents and the patients and the staff exposed. Remember, I mentioned multimodal and multidisciplinary intervention. But what is missing, one of the largest things that's missing in multimodal and multidisciplinary integration is communication, cooperation, and collaboration. Communication is speaking to someone and that person listening to someone, listening to what is being said, just communicating back and forth, understanding, or saying, I don't understand, please explain. Cooperation means working together. I will let you do this if you do this, or I will work with you to do that. And collaboration is, let's work together. But without communication, cooperation, and collaboration, there cannot be any multidisciplinary integration of our infection prevention processes, including dealing with textiles. The 3 C's, as I call them, has to be between the owners, the administration, nursing leadership, infection preventionists, risk management, quality management, and the frontline staff. On page 24, we have another F tag. CMS says personnel must handle, store, process, and transport linens as to prevent the spread of infection. I have seen too often where people understand I'm going to deal with the clean textiles, the hygienic textiles one way, but how am I going to deal with the contaminated textiles? There's no way for them to know, so they contaminate themselves, their uniforms, guests, residents, patients, and more textiles, and all the surfaces in a facility. Page 25 is just a listing of references for microorganism survival on uniforms and clothing. And that's one area that most people fail to recognize, and an area that most hospitals and nursing homes do not want to address. That clothing gets contaminated with pathogens. And it's not just their shirts, it's the entire uniform. It's not just nurses' scrubs. It is whatever they are wearing to work. And if they don't change out, they're going to wear that on the bus or in the car or on the train. They're going to get it, contaminate their car, the bus, the train, their washing machine, and potentially their families. I am a big proponent of having uniforms, both scrubs and working uniforms, provided by healthcare facilities and laundered by healthcare facilities. Now, let's look at page 26. We have sources for infectious microbes. You have the patients, of course, the staff. The hands of the environmental surfaces are the main transmitters of healthcare-associated infections, followed by work clothing and other inanimate objects. We all heard this years and years ago. I think it was by Alexander Haig, who said, trust but verify. That's an old Russian saying. Trust that environmental services, that laundry management, that infection prevention, that risk management and quality management, trust that they're going to do the job, but everyone must verify that the jobs have been done. Each person has a responsibility to their own job, but they have a responsibility to help ensure that others do their jobs. Now, when we're doing laundry, a lot of people say, well, I'm going to wash it in this top-loading washing machine. Or I've gone to one of the big box stores and bought a front-loading washing machine so that we can do our residents' clothing. Oh, and we'll also do their bed linens. But the problem with non-commercial industrial machines is they cannot provide the time, the temperature, the product concentration, nor the mechanical action. And the majority of textiles coming out of non-commercial machines at facilities are the textiles are not coming out hygienic. Washing linen is only one part of the process of providing clean linens for storage. Each stage of the linen flow cycle, from washing, finishing, transporting, storing, and to the point of use, involves various opportunities for contamination of linen. If proper training, cleaning, and processes are not enforced, there has to be regulations, there has to be processes that must be enforced. It's no good to have one if you're not going to enforce it. And here is the best practice. Take this home with you, regardless of where you live in this world. Every surface that touches the healthcare textile must be as hygienically clean as the textile itself. Back in 2012, we had a study done by Fajin and Turk. It was entitled, Hospital Textiles, Are They a Possible Vehicle for Healthcare-Associated Infections? The answer is yes, they are. The other answer was answered by Dr. Seeholster in her study that showed the majority of textiles, when they're laundered according to the proper steps and proper processes, they pose no harm to patients or residents. It's when something happens to break the chain of the proper process. Back when she wrote the article, there were only 12 worldwide infections that could be attributed to healthcare laundry. But that's because healthcare laundry operations, primarily commercial ones, know what they're doing and have been doing it for a very long time. Now let's look at the processes for handling clinically clean HCTs. All contact with clean healthcare textiles and isolation gowns needs to be above the waist. When patients are in their bed or when environmental services people come in to change the bed, they lean against the bed and contaminate their uniform or their isolation gown. So the process has to be reinforced that clean HCTs, healthcare textiles, must be carried above the waist. I understand that I'm moving quickly here, but I also understand that so many of you have time, that you're vested, and that I'm just trying to save time here, and I hope that you appreciate all the information that we have here. Let's look at page 37, or slide 37. If healthcare textiles must be left unattended, either in carts or in corridors, or oftentimes at charging stations, the cart and the station should be clean, disinfected, and capable of being locked so as to ensure the hygienic integrity of textiles. Remember what I said, the surface has to be as clean as the textile. So before something is placed on it, before textiles are placed on the surface must be clean. If it's not clean, then the textiles touching the surface are no longer clean. Let's look to page 40. I think this is going to be very interesting to you all. The art of proper linen management. This is something that I find interesting. And of course, we have a pink and a blue horse. Managing linens and laundry. Use your standard precautions. Observe hand hygiene practices all the time, because if they're going to be touching clean textiles, their hands have to be clean, or they have to be wearing gloves. They have not touched anything else. Fold or roll heavy soiled laundry. Avoid airborne particulates. Don't shake sheets, blankets, towels. Hold the soiled linen away from your clothes. Remove large amounts of soiled waste, solid waste first. In other words, if there's a bowel movement on a sheet or on an incontinence pad, it needs to be flushed down a toilet, and then the pad can be laundered. And place the soiled laundry into a bag in the patient room. We also have to look at this. Clean linen should be stored in closed closets or covered carts. Clean linen shall be covered with while being transported in a dedicated cart. So you can't transport clean linen in the same cart that you've transported dirty linen or bagged garbage. I'm moving along. I'm up to page 46 here. Freestanding hampers. A lot of people in hospitals and nursing homes, the environmental services people, they tend to throw their back out, cause injury to their back, because they're trying to pick up bags of textile or of healthcare textiles, soiled healthcare textiles, and the bags are too heavy. But if you're using a freestanding hamper, you can only get so much in there. When the bag is full, it should be removed, closed, and then removed to a soiled utility room. Linen bags should be stored, should be used up till it's 1/2 to 2/3 full. So the bag can be closed, can be sealed, and does not cause any bodily harm. And believe me, the older a person gets, the less they can carry in front of them. Here is another thing. So many people think, well, I've got blood or I've got urine or I've got feces on this sheet or on this bed pad. It has to be thrown away. According to OSHA and the CDC, those products should be double bagged, put into bags that are leak resistant, and laundered with the regular laundry, because our laundry processes can remove all of the blood products, the potential pathogens, the germs. Let's look at page 48. And this is a very easy thing to do, that we can do. Look at the picture. This is a picture of a laundry cart. It has a cover on it. All the linens are fully covered. There's no other items on the cart or in the cart except for linens. Here's a picture, the next one, page 49. Linen carts are not to be stored in corridors because they will block a corridor, restrict the size of the hallway. And we have to be concerned, even though there's never been a fire, there may be, and we don't want a hall to be blocked by carts. Store them in non-egress areas, and store laundry carts in a clean utility room. Here's another picture of a very large cart. It has shelves on it. It's dust covered, fully covered linen. There are no items stored on the cart. And when I talk about items, I'm not talking just about the healthcare textiles. I have seen stethoscopes up there, pulse oximeters. I've seen boxes of face masks and boxes of disposable gloves. You would be surprised what you would find up there if people are not doing their job, if they're not verifying, trusting and but verifying. Here's another picture on page 51. Soiled linens in moisture resistant. In this case, we're using yellow bags, but they don't have to be yellow bags. They can be whatever color bags you want. They can also be in plastic bags, leak-resistant plastic bags. Fill the bags, as you can probably see, they're 2/3 full, and there is no there's no linen being shown. Now here's a question. Have you ever seen linen carts, linen trucks piled with linens like this? The first person to call is your linen supply people, the ones that are on your staff. The second one, if it doesn't get resolved, you call linen management, because this is a problem and this is an accident waiting to happen. Now, here's the fun part. Review the following slides on page 53 for all violations. You see this cart here? What is the violation? It's a laundry cart. You see linen in it. But what's the violation? The cart is stored in a public area. It's for transport of clean linen. It's not designed to be stuck in the hallway. And most importantly, the dust cover is mesh. So dust and other particulates and moisture can get in there and contaminate the textiles. You will also notice that this cart here is, for all intents and purposes, empty, so that it should not even be out there. It should be back into a clean area so that it can be washed down, disinfected, and have new textiles put into it. Here's on page 56. Here's a violation. What's the violation? There's clean linen on top of the cart. And the clean linen that is on top of the cart is now considered soiled. This happened because a nurse or an environmental services person took too much linen. This looks like towels, took too many towels, realized they couldn't put them back into the cart, so they left it on top of the cart and failed to recognize that what they did is now contributed to the contaminated or soiled textiles. Here's another one. Here's a violation. I've seen this too often, and possibly so have you. We have, what's the violation? Storage on top of the cart. And we also see that the cart is covered with mesh fabric. So it's not keeping the textiles inside the cart free of dust. So those textiles are potentially contaminated. Here is a violation. I've seen this, and so have many of you. What's the violation? The soiled linen is uncovered. If you look at the bag on the left side, you'll see that that's open. It's open to the soiled healthcare textiles inside. You also have bags on the floor, and that is not permissible. What's the violation on page 62? What's the violation? The bags are too full. They couldn't be picked up. They were dragged to the cart, and they were left there because the person who dragged them could not pick them up. So the bags are too full, the soiled linen is uncovered, and the linen bag is on the floor. Another, and these are not staged, these are real pictures that we picked up as we went along. What's the violation here? Soiled linen is uncovered, bags overflowing onto the floor, and in the center, soiled textiles coming out of the bag. What's the violation here? The soiled linen is not in a bag, and it must be in a bag. I want to take this time to thank you for keeping our residents and our patients safe. I thank you for your attention, and I thank you for your time. Enclosed on page 69 are the references. There are links that you can see and go to. And hopefully you've learned from this session, and that you'll take the time to go back and review so many of the slides that we just didn't have enough time to go through and concentrate on. For more information, here's my contact information. And one of the things that I live by is this saying, what is done is important, but more importantly is how it is done. I thank you for investing your time in viewing this presentation, and now I'm going to turn this over to Dr. Seeholster.
Well, thank you, John. I want to say I have learned an incredible amount of information, and how to put it, at CDC, we don't normally get a lot of training about the logistics of moving healthcare textiles from point A to point B and doing it safely and keeping the quality of those textiles intact. And so I think there was a great deal of practical applied information here that people from a variety of healthcare institutions can put to their use. Since you have an additional at least 5 minutes available, do you want to elaborate on any of the points that you've made in your lecture?
Well, thank you, Lynn. I would like to elaborate on one main thing, and that is something that I did not address here, and that is common sense. We all have heard the term that common sense is not so common. But common sense also gets down to avoiding knee-jerk reactions, avoiding situations that we have a question about. I've always been taught that good common sense brings to mind the question of, should I do it or should I not do it? Is it the right thing to do or not to do? And common sense will also bring you to a point of realizing that if your mother would not want you to do it, then you should not do it. That brings me also to one point that one term I've been using for years, and that we do have medical ethics. We do have ethics that we are, as a chaplain or environmental services or a nurse or a researcher, we have ethics that we are supposed to follow. But when it comes to treating patients, I use the term the ethics of mother care. If you would not do something to this patient, if you would not do it to your mother, then don't do it to the patient. That is, of course, assuming that you have a good relationship with your mother. So the ethics of mother care is common sense, and if you wouldn't do it to your mother, then don't do it to somebody else. If you would do it for your mother, do it for someone else. That's essentially what our life is supposed to be, and that's what infection prevention is, and that's what healthcare laundry is. Doing the right thing for the right reason, regardless of who you're doing it for or to, because they have value. They may not have value that your mother has to you, but they have value to someone else. So treat others the way you would want them to treat you. Treat your healthcare textiles the way you know they should be treated. And if you see an infection prevention issue, speak up. Yes, you trust your infection preventionist to do his or her job. You trust your environmental services department to do their job. But oftentimes, you have to verify what they're doing. And you can verify something very easily without insulting anyone or without demeaning. You can always ask a question. And questions usually will lead to answers. And if the answers don't sit well with you, then thank the person for the answer and find another person that has a different viewpoint. But always do what you're doing for the right reason. And in this case, do it for your mother. Thank you, Lynn.
Well, thank you. I'm looking at your for information slide here, and again, you reiterate your words of wisdom. What is done is important, but more importantly, how it is done. And I think a corollary to that is, from my point of view, in giving lectures to audiences and so forth, my objectives are to convey an understanding of what you are doing, but equally important, why you are doing this. And a third thing is how you are doing it, because if you understand how a particular process is done, the importance, I'll give an example of cleaning and disinfection. With cleaning, it is soil removal primarily, whereas disinfection is a chemical and activation process. And so if you understand the importance of each one of those steps and what is accomplished in those steps, then you understand the importance of the overall process. And so you're better equipped to recognize when things are not done properly, or corners have been cut to make a process easier or faster to do. But in the long run, you may shortchange the overall objectives because you haven't completed the process correctly. And so I'm sure both you and I have the same feelings, that we try to impress upon our audiences that it's very important to do things the way they are meant to be. So with that, I want to thank you for all you have done for healthcare throughout your career and what you are currently doing now, which is incredibly important as we move further into the new challenges for environmental services. So on that note, I'd like to move us, oh, you're quite welcome. I'd like to move to slide 71 for our audience to give you a listing of the upcoming teleclasses. Some of them are free. Yay! All of them are very important, and do pay attention, I think, for the teleclass that is free on October 20th. Professor Didier Petit from the University of Geneva Hospitals is giving a lecture in observance of Clean Hospital Stay, and I think this is going to be a very important topic, one that will address the present-day challenges that environmental hygiene, environmental services will face. There are also a number of very interesting topics coming up. I see it's at the very bottom for December 2nd of 2021, Emerging Fungal Infections and Infection Prevention and Control. That one in particular, I think, for those of us who have been trying to understand fungal infections as they relate to healthcare textiles and the patients who use these textiles. This is an emerging problem, and I think this one would be well worth your time and attention. They all are worth your time and attention. So by all means, if you do have the interest in the topics, please join the teleclasses on this schedule of events. And our final slide in this slide presentation acknowledges the support to teleclass education from the patron sponsors, Diversity, Virox, Gamma Healthcare, Purell from Gojo, and finally the World Health Organization, specifically their Infection Prevention and Control Global Unit. So on that note, why don't we say we will see our teleclass audience in future teleclasses. We thank you for your participation today. Hope you learned some good information. And again, thank you to John Scherberger, our speaker today, for an excellent presentation. And once again, thanks to Dr. Sattar and Paul Weber for all they have done these past 20 years in support of teleclass infection prevention education. And on that note, I'll say thanks for attending, and we will see you next time. Have a great day, and thanks.
Thank you.